this meeting of the Primary Care Access, Delivery, and Payment Task Force. I'm David Seltz, Executive Director at the Health Policy Commission and proud co-chair of the task force. Welcome to this first meeting of the task force here in 2026. Despite what that says on the slide here, it is, yes, indeed, 2026. And very excited to continue the important work of this task force and really build off of the momentum that we've had in the past about 8 to 9 months as we've continued this really important work. I'll give an overview of today's agenda and what we hope to discuss today and what we hope to continue to make progress on. But before I do that, I'd love to just turn it over to my co-chair for some opening remarks.
Yes, thank you, David. Always glad to be at a primary care task force meeting. I think it's you're probably very well aware that the ferment that surrounds healthcare has not diminished in the month that we've been apart, and it's clear that we are now at a crucial point, both nationally but also state, in terms of what actions, what changes, what paradigm we're going to be using over the next decade or so in terms of delivery of care and payment of care. So you are in the crucible, you are at the vanguard, the changes that are going to be coming upon us, and I look forward to continuing work of this task force. David?
Thank you, Mr. Secretary. Indeed, in the crucible. Before we go further on the vanguard, we do have one matter of business to take care of, as we always do at the beginning of these meetings, which is to approve the minutes from the last primary care task force meeting, which we held in person on December 3rd. And since we are not in person today and we are going to be doing this virtually, we are going to need to do this by a roll call. So first, I will ask to see if there is any edits or comments or questions on the minutes as circulated. Seeing none, I'd be happy to entertain a motion to approve the minutes.
So moved.
Thank you. And a second?
Second.
Great. Thank you so much. And so I'm just going to go through and read off the roll call and ask for a yay, a nay, or an abstain. So I'll start with you, Secretary Mahania.
Yay.
Senator Friedman.
Abstain.
Representative Lon. I didn't see him quite yet. I'll come back to him. Commissioner Caljo.
Yes.
Caitlin Sullivan from CHIA.
Abstain.
Dr. Ryan Schwartz.
Yes.
Dr. Wayne Altman.
Yay.
Laura Black.
Yay.
Jennifer Blewett.
Yay.
Thank you. Allison Bracken.
Yay.
Dr. Renee Critchlow.
Yay.
Thank you. Suzanne Curry.
Yay.
Thank you. Dr. Eric Dixon.
Yay.
Thank you. Dr. David Gilchrist.
Yay.
John Hurst.
Yay.
Thank you. Dr. Stephen Martin.
Yay.
Thank you. Dr. Judith Mellon.
Yay.
Thank you. Sarah Mills.
Yay.
Laura Pellegrini.
Abstain.
Thank you. Brenda Anders Pring.
Yay.
Thank you. Barbara Rapson.
Yay.
Thank you. And I know Christina is unavailable to join us today. Dr. Spivak.
Yay.
Thank you. And I think I just did see the chairman join. Mr. Chairman, we're just taking a vote on the minutes. Yay, nay, or abstain. Oh.
Hey, sorry, David, just signing on. What was that?
Just taking a vote on the minutes.
Oh, yay. I have a yay.
Thank you.
Yep.
And I'm so sorry, Dr. Friedberg.
Yay.
Thank you so much. Did I miss anyone else? If so, I apologize. Seeing none, the motion passes. Thank you so much. The minutes are approved. All right, so we can dive right into today's agenda. First of all, I just want to share a little bit of just a little bit of a logistical change for today's meeting. We had originally planned to go from 10 o'clock to noon today. There has been a slight change in plans, and we are going to have to end the meeting a little bit earlier. So we'll be closing the meeting today around 11:20, 11:25. There are a few of us who have a prior engagement that is going to require us to be leaving a little bit early. But nonetheless, looking forward to a great discussion today. Where we thought, the co-chair and I thought we would want to really spend our time today is to continue a conversation on statutory deliverable number 4, which is really focused on payment reform. And here, this is going to be the bulk of our conversation today. And I'll tee this up a little bit in terms of what we hope to gather from this group today in terms of feedback and input as we continue to make progress on this particular set of recommendations from the task force. Originally on our agenda today, we had also planned to bring to this group a little bit of a conversation on statutory deliverable number 5, which is around assessing the impact of health plan design on primary care, access to primary care services. This was a conversation that we had at a data and research work group meeting. I think in the interest of time, I will briefly describe that task, that specific deliverable, but ask for some feedback and input offline after today's meeting. But save some of the time today for a final open discussion on priorities and goals for the primary care task force and the work of this task force in 2026 to close out today's meeting. So we'll have some time for some open discussion here at the end of this meeting. So turning to statutory deliverable number 4, as a quick reminder, we were able to put out a series of recommendations at our last meeting around establishing a primary care spending target. As we noted at the time and continue to note throughout the work of this task force, all of these different deliverables are interconnected and interlinked together. And not one of these recommendations alone stands alone and will achieve, I think, the goals of the primary care task force alone. And so as we think about how these different pieces fit together, it's important to think about the interconnectedness of these. And we recognize that as we were putting together deliverable number 3 on setting a primary care spending target, and we included some language in that recommendation really highlighting the link between a primary care spending target and the need for primary care payment reform. And so I just wanted to highlight this language here on this slide that we included in deliverable number 3, linking these two ideas. So in deliverable number 3 on the primary care spending target, which called for an increase in the share of spending on primary care to 15%, or double the share within 5 years. We also included in with that recommendation this text that said increases in primary care spending should be prioritized by payers and providers to support the adoption of innovative payment models that support the delivery of the 4 pillars of person-centered primary care, and the 4 Starfield C's follow. We also noted that the recommendations from this task force on payment models would be further discussed in the upcoming primary care statutory deliverable number 4. And so that's really where we wanted to pick up today's conversation, is talking about how we think about linking the idea of increasing the spend on primary care with the idea of that increased spend being used to change the way that we pay for care that supports a change in the care delivery. And so that all of these concepts, again, are linked together. This was a big topic of a conversation that we had at our October task force meeting. If you'll recall, at that particular task force meeting, just 3 short months ago, we talked about, and we had a presentation on the Fairhey report, which looked at a number of different states and their proposals and different initiatives around primary care payment reform. What were some of the key features that other states had undertaken in terms of primary care payment reform? What did the literature tell us about primary care payment reform, and what were some of the key principles? We reviewed the primary care subcapitation program. Dr. Ryan Schwartz gave a great presentation, and I felt this group and this task force had a really great discussion about some of the key conceptual ideas that were a part of the MassHealth primary care subcapitation program. And many of the task force members reflected that there were some really promising ideas and components and principles that were a part of the MassHealth primary care subcapitation program that we should be building upon as we think about this particular set of recommendations. And we also discussed what some of the legislation pending before the Massachusetts legislature has in terms of ideas around primary care payment reform. And so for today's discussion, what we wanted to reflect back to this group and have a discussion about is really taking some of that conversation, the previous presentations, and synthesizing some of those principles and goals, and really wanted to reflect this back to this group to further solicit your input, feedback, and reflections on what are the goals that we have for reforming primary care payment. What are we trying to achieve by changing payment for primary care? And then with an idea of what those goals are, what are the principles for the design and implementation of primary care payment reform that we might include as part of a set of recommendations? Today, we are not proposing to have a final deliverable here for discussion. This really is an opportunity for further conversation, further discussion. We hope to hear your feedback, your input, as we further refine this set of recommendations. And then even after this meeting, would very much welcome your continued feedback, input, comments, edits. And so this is really an opportunity to kind of continue this conversation. So I'll run through the next 3 slides at a pretty high level. This is kind of our attempt to synthesize the conversations that we've been having. And then I'll pause and really open it up for conversation, which my co-chair will help guide. So this first slide, I think we wanted to start with what are the goals that we are trying to accomplish by primary care payment reform? And then having an idea of the goals, then move to what are the principles that would help achieve these goals. So first, is a statement of what are we trying to accomplish here? We're trying to realign the reimbursement models, again, around this idea of the 4 pillars of primary care. And among these core goals that we're trying to achieve in terms of changing payment, we are proposing a number of different core goals here. Improving patient access and experience. By changing the payment, how can we enable provider flexibility to provide the right care to patients at the right time and in the right location that meets patients where they are where they best need it, to provide the care when they need it? So thinking about how payment can enable provider flexibility to do things like extended hours, to do things like telehealth, to do things about being able to provide that real-time visit to patients when they need it in the type of modality that best serves that patient. How can payment help enable that? How can payment reform strengthen primary care capacity and stability? How can we use payment reform to provide reliable resources to practices so that they can hire the staff to be able to do that type of improved patient access and experience, to hire the type of staff, to extend hours, to invest in technology and enable innovation? How can payment help support team-based care models and reformed payment encourage the integration of behavioral health and other supportive services? How can reformed payment improve the quality of care, the outcomes of care, and reduce health disparities that we know and advance health equity? How can payment reform help reduce administrative burden if we can simplify and align billing, reporting, and other requirements that go into our interaction with the payer system? And then finally, can we leverage payment reform to enhance workforce stability by reducing burnout and improving the work experience of primary care providers? So these are a set of potential goals that one might think of in terms of why and what we might try to accomplish by reforming payment. And so very quickly on the next two slides, what are the principles then that we might think of in terms of design principles that might us achieve those goals? So first here is a principle around shifting from fee-for-service to prospective capitated payments. A second principle would be that these payments should be directed to primary care practices directly or for the services that directly benefit primary care practices. A third principle is that these principles should be aligned across payers and patient populations, not only within the commercial sector, but across sectors. That there should be meaningful multi-payer alignment on payer reform reporting requirements and other operational parameters to decrease administrative burden. That primary care payment should recognize enhanced care delivery capabilities and quality performance with payment adjustments. Next slide. That there should be equity considerations built into the primary care payment development, such as risk adjustment for social factors. That when we think about commercial primary care payments, should we consider including baseline levels that are indexed to public payer benchmarks? So for example, having a commercial payment floor for primary care providers as a percentage of Medicare, or for FQHCs that's at least as much as mass health payment. That there should be robust monitoring and of the effectiveness of these primary care payment reforms. And of course, that the primary care payment reform should be aligned with our primary care spending target and the commitment to cost neutrality that we made in our last deliverable. So I've thrown a lot at you in terms of goals and deliverables. I think let's return back to the slide on goals and start there. And then that may help us inform what are the principles for primary care payment reform that will help us achieve these goals. So I'll start here in terms of what are the goals of why we should try to reform payment reform. What do we want to accomplish by that? And we'll really just open it up. And Secretary Mahania, happy to work with you on kind of facilitating a conversation here.
Thank you, David. There was a lot, but presumably a lot of it is familiar. Just into the mechanics, we have about 40 minutes dedicated to this particular discussion. So that means if everybody were to speak once, it would be around between 1.5 minutes and 2 minutes per speaker. So if you could just keep that in mind as you are making recommendations. It's also always very useful, particularly in this kind of setting, to focus on what you don't like. So if you could start with like what you like about a particular slide, and then launch into the things that you don't like. That way we have an idea of balance. And I will try to keep time if it looks like so you're going way beyond 2 minutes, but I'll try to let you guys sort of fully express yourselves. And it looks like Laura has her hand up first.
Thanks. So I think this looks good with a couple of comments. I think obviously strengthening capacity is key if we're going to be successful in reforming and changing primary care. We very much support the team-based model approach and think the systems are well positioned today to probably start that work. I would say on reducing administrative burden, I think we need to put electronic medical records in there. I've talked to a lot of primary care physicians who have been in the press or whatever saying they're burned out what they talked to me about is particularly Epic and the requirements that they're required on the Epic portal. So I would, I see Wayne putting a thumbs up. So I think we need to add that on electronic medical records and requirements there. And obviously, the state and NCQA and others have certain reporting requirements for us, HEDIS. So I think that it would be important. I'm sure HPC would do that work to ensure that we don't affect any accreditation. But I think the rest of this looks good. So those are just some of my comments.
Thank you, Laura. Allison?
I agree. The strengthening primary care capacity, I think, will improve patient access and experience. I was just wondering, like other states that have increased spending on primary care, have they earmarked for certain, putting money towards, certain goals, or is it, do we have any kind of experience with how that went? Like, can we say this amount has to, a percentage has to be towards, hiring staff or hiring PCPs, or is it more carte blanche that how practices utilize that increased spending? I don't know if I don't know how that would work across such a big, throughout the state, through so many different types of primary care practices.
Yeah, I'm happy to share a reflection on that. Many states that have done a primary care spending target have paired that initiative sometimes with goals around, sometimes they're called APM adoption, but essentially goals around how many either patient lives that are underneath kind of a primary care payment reform model, like what we're kind of discussing here, a capitated or a prospective payment model. In terms, Rhode Island, in particular, I think when they talked about their primary care spending target, they really encouraged payers to think about trying to meet that spending target through non-claims payments. And so kind of thinking about kind of not just increasing kind of the fee-for-service rates necessarily, but really around some of those more flexible payments to primary care practices that one might think may enable, kind of the kind of number two, right? The kind of the non-reimbursable types of supports and services that one might want from a practice to be able to do that go beyond just kind of what is reimbursable in the fee-for-service. And so I think there are some opportunities for states in terms of the implementation of this to perhaps put a little bit of a, so to speak, a thumb on the scale in terms of what the priorities one would want to see the payers and providers as we're trying to set a primary care spending target, in what directions we would want to see them try to prioritize. And I think that's part of what this conversation is about too, is around trying to say, we want to see this move towards a shift in the primary care spending model towards one that is a more prospective capitated model that would enable some of these, more flexible types of approaches to care delivery.
David, Mark, Renee, Wayne, and then John, and then Eric. So David.
Great. Thank you. So I like the goals. I think the list makes a lot of sense. It's what we've talked about. Just one addition. I mean, I appreciate that the part of the reason that we're here is around the cost of care, but it's not really explicitly called out here as a goal, right? I think we can do all these things, but if the cost of care continues to rise, that's really an unsustainable situation. So I don't know if in the list of goals, there should be something around cost or medical spend.
Thank you, David. Mark?
Yeah, thank you. I think there's a lot of good ideas here in the principles. Just want to offer a few comments on them. One has to do with the principle that suggests paying for delivery capabilities. I think that's principle 5. There's actually a large amount of literature on this. Unfortunately, it hasn't worked out. It seems like it should. The entire patient-centered medical home literature has shown just failure after failure. And it's worse than not helping patients. It's actually contributed to quite a bit of practice and primary care practitioner burnout in state after state and nationally in every federal experiment that's been tried. If were to go down that route, it really increases the importance of evaluation that is external and rapid and free of any kind of interference in terms of sharing the evaluation results as quickly as possible so we can do course corrections. Early indicators there might include qualitative interviews and other ways of gathering data from the practitioners who are being asked to make investments in things because they need to meet some kind of structural capability to enhance their payment. There's another bullet on here that I just wanted to say, bullet 7 on baseline labor levels of payment for commercial payers indexed to public payer benchmarks. That just really increases the importance of having a really robust mechanism for making sure that commercial premiums and out-of-pocket spending cannot go up even in the short term as a consequence of any of this reform. I know we've talked about that before, but this is definitely a vulnerability because the tempo of government changes in payment can be very different than the tempo of commercial payment, which is highly regulated and has a pretty big lag to it. Finally, on the one about equity considerations, number 6, risk adjustment for social risk factors. I'll just say that that has to be done with a great deal of care. I know Dr. Cricklow is a real expert in this area, and I have more to say about this, but you have to get very clear about what you mean by equity and do a really careful audit of the risk adjustment, which is a kind of algorithm. And algorithms constructed with the best intentions to try to close equity gaps, all too often instead increase them. Thank you.
Renee, Wayne, then John.
Mr. Secretary, if you don't mind, can I just follow up with a question for Mark? First of all, Kelsey, would you mind just forwarding, I think, 3 slides so we can, he was reflecting, I think, on some of the one more. So task force members, we were previously showing you the slide with the goals. Here are the slides with the principles kind of more on the design side of the primary care payment reform. So goals and principles. And so, Mark, you reflected on, I think, number 5, primary care payment reform should recognize enhanced care delivery capabilities and quality performance. Number 7, around perhaps indexing to public payer benchmarks and saying we got to make sure that doesn't increase total cost of care. Number 6. And 6, equity considerations. Be very careful in how you do so. Could exacerbate a problem if done not well. I just did want to maybe feel other task force members feel free to offer your comments on any topic that you feel most appropriate. But I did want to ask if people did have thoughts on number 5 and number 7 in particular, on this concept of should there be payment adjustments for enhanced care delivery capabilities and quality performance. That is something that we had talked about is part of the Mass Health subcapitation program. They do have different tiers of performance and payment adjustments that go with that. That is something that I think is contemplated in some of the pending legislation. So would be interested if any members have further comments on that particular piece. And then on number 7, this was, again, a concept that I think was discussed by some members, and I wanted to reflect it here around this concept of should there be a baseline benchmark for commercial payments that is tied to either as a percentage of Medicare or in the case of FQHCs, that they should be at least at what Mass Health is being paid, and what task force members may think of those. So please feel free to comment on anything, but if you have thoughts on those, would love to hear it. Secretary Mahoney, I'll go back to you, but I think Renee is up next.
Yes, Renee, please go ahead.
Yeah, so perfect timing, David. What else? Can you hear me okay?
Mm-hmm.
Great. What I wanted to comment on, I do think these are good and good baseline for us to begin with. But I think probably what I want to be able to stress right now is on, equity considerations and quality considerations. If they come with more administrative work, they're useless. So that has to be just understood. The second part is if you really want to improve decrease disparities, improve equity. That is about expanding access to primary care across the state. That's it, full stop. We don't have to do any more dancing around. It's about creating more access. What I do like about what Medicaid has done with the subcap is they've said, you can be on tier 1, 2, or 3. And that's the way that I feel that they've done a good job of saying how much, extra effort is being put in. I have community health workers. I have BH integrated. I have group visits. A suburban practice with, high wealth individuals may not need that. But we all need, in my mind, the biggest part is providing the prospective payments so it allow us to do the team-based care on a consistent basis. And one of the biggest things I want to see go away is I should be able to pay the same amount of money for a primary care physician salary that BI and MGB pay. Because I'm providing primary care. They're looking for people to do more referrals. But what they have is they have the insurers by, the throat. And they say, you have to pay us more. That has to go away. I should be able to compete for the same physician because I can pay them the same. I should be able to pay for the same nurse because I can pay them the same. And my last part is, I do consistently believe that simplification of billing, simplification of quality, all of the things that make us have to spend money outside of the clinical dollar must go away. And we will know that we're doing the right thing when we have more people going into independent practice, when it's so simple that you can go into independent practice. And I can tell you that that is going to be a much better anchor on the big systems than setting up many commissions to follow where the dollars go. No, if people can leave BI and set up their own practice, guess what? BI is going to make sure that the primary care dollar flows to the primary care clinics. That is what's going to do it, is competition. And I, as a FQHC, I should be able to compete with MGB and BI for the same doctors, for the same NPs, and the same RNs. We set it up right. There's no favorites. Everyone gets a level playing field, and that will guarantee that BI and MGB and all the big systems will take care of their primary care clinics. Because if they don't, those people will come work for me, or they'll go work for themselves. That is the critical part. Thoughts?
Wayne, then Ron.
That, Renee, thank you so much. I think the goals and principles that you've laid out, David, are outstanding and are comprehensive and really thoughtful, and they're very much aligned with the principles that we've outlined in our primary care for you payment model that we've been working on for 7 years. We have been working with Senator Friedman and many others and stakeholders from all over the state on this payment model for 7 years. And you really have aligned these principles, or these principles are quite aligned with what we've been working on, with one notable exception, and that is the establishment of a primary care fund that pays primary care practices directly. And the concept of this fund, there's a few fundamental reasons why this fund is essential in what we do and what we recommend as a primary care task force. If we do all this work for 7 years, and then this primary care task force over 2 years, and all the work that people on this task force and others have done, and then we end up with a primary care legislation that is passed that does not include self-funded plans, which are 60% of our commercial market, or 2.4 million people in Massachusetts, we will have failed. And, well, I think that's too strong. We will have not done as well as we could have done. And the folks who would concur with us are folks from Delaware who are lamenting that mistake, that very mistake, and folks from Rhode Island. When you talk to PCPs in Rhode Island who doubled primary care spend, There are no PCPs in Rhode Island talking about the Halcyon and the wonderful existence that they have in primary care in Rhode Island, because it had such an anemic effect and didn't affect any of the self-funded folks in commercial insurance. And Dr. Critchlow likes to talk about the Common Fund, this primary care fund that we've talked about. Renee has renamed, and I love it, the Common Fund for the common good. The other piece that Renee spoke about was rate and
Time. Keep going, but you're 2 minutes and a half already.
Okay, I'll wrap up. Thanks, Kiame. Rate inequities and the ability to recruit the physicians and other folks at the same salaries. And when you establish a primary care fund, you have the ability to address those rate inequities. Whereas the insurance industry, as much as they would love to, they're beholden to market power and are not able to do that. Thanks for the time.
Thank you. John, then Eric.
Yes, thank you. David, back on the original slide, I saw a lot of goals, a lot of words that began with the letter C. All important goals, but nowhere there is the words consumers nor the word choice. And I think we're dropping the ball if we're not really focusing on the consumer and their right to choose in order to get the best care at the right price. And what I mean by that is, on number one, but it really affects all of these. If we don't give the consumers the choice to really through their insurance policy, through them as subscribers to choose a plan that really allows them the flexibility to go to a primary care provider that they choose to do, and for instance, direct primary care. If we're going to really foster direct primary care, insurance plans need to reflect that. That's consumer choice. We were just talking. Wayne was just talking about self-insured plans. Well, that's consumer choice, Wayne. Employers are going to self-insured plans out of choice in order to save money, in order to have more options. We need individual consumers, actual premium payers, subscribers to have choice to get the kind of care that they want and have it reflected in their premiums. So they can go to a direct primary care who can then have less administrative burden, can have more workforce stability, can have more capacity, more stability, give their patients more access and more experience. We're missing the boat if we're not keeping the focus on the consumer, the actual premium payer, and allowing them the choice to buy the insurance that would really help them and their families.
Thank you. Eric, then Judith.
Thank you, Mr. Secretary. I start every lecture I give on healthcare right now talking about the one megatrend that we absolutely cannot ignore, and that is the aging of the population, the increase in disease burden that is coming, especially starting in about 2025, and the lack of providers. We don't have enough providers to take care of that increase in burden and disease burden that is coming and is already here, which is why we don't have adequate primary care access today. We can't create the workforce fast enough to manage that aging of the population. We have to look at new models of care that keep people home healthy, their chronic disease managed. I think we have to rethink a lot about how primary care is delivered and look at new models that incorporate mobile integrated health, remote patient monitoring, medication adherence monitoring with patients, leveraging AI. And I do worry a little bit, like Mark had mentioned, that if we're going to go back to team-based care models, which failed under the patient-centered medical home, and we did those, that's just not going to be enough. I think we need to add a goal of new care models that can keep people out of the emergency department and out of the legacy bricks and mortar hospitals where care is delivered least efficiently. Thanks again for the opportunity to speak.
Thank you. Judith, then Barbara Rapson.
Yes, thank you. I'd like to emphasize, most of this or all of this is excellent. I'd like to emphasize a couple of key items that are either there and could be embellished or that I'd like to see added. Prospective payment is critical for the reasons that we've discussed before. And I'm going to add the word front-loaded. And by that, I mean rather than the 5 years that we anticipate recommending for a ramp up, I'm going to recommend that we front load as much of that funding as possible, thinking about the many cycles of residents and medical students who will emerge within the next 5 years and could be interested in primary care if only it looked hopeful, and thinking about our current practicing colleagues who are hanging on, burnt out to various degrees, and may not feel that 5 years of hanging on as is doable. So ensuring that we front load to provide not just hope, but some tangible resources to achieve this. And another, a new principle, assuring that any cross subsidization or whatever word you want to use for it, that is currently employed by very large entities to somehow keep primary care going, is recognized in addition to the fee-for-service payments that we're counting, so that this ultimate 15% increase doesn't wind up being an overall decrease or de minimis increase to the percentage of dollars, the actual amount of dollars that they're getting. And finally, in concert with, excuse me, with what was just said by Member Dixon, there are so many aspects to primary care that we haven't yet measured, but that are key to helping our patients. In the midst of this flu surge that we're having, being seen face to face in an exam room is probably not nearly as good for most patients' health as is the opportunity to have a telehealth visit, or even better, to speak with a triage nurse. That triage nurse isn't a billable event now, so we aren't going to know about it, right? But the patient's going to know, because that nurse is speaking every day with numerous patients with the same symptoms. And she really knows what to tell the patient to do and watch for. I want to get a practice that has that credit for offering it. Thank you.
Thank you, Barbara Rapson and Barbara Spivak.
Thank you. So I really like the goals, so thank you for that. But if you move to the principles, we are missing a principle that says we need incentives to keep patients healthy, because that is what's missing. We've known the evidence that says primary care is the one specialty that keeps patients healthy, yet in Massachusetts, the decisions we've made has led to a decrease in primary care spending as a percent of overall spending over the last several years. And all of the challenges that Dr. Dixon and others have talked about the aging population. And if we don't acknowledge that we need the incentives to keep people healthy, then the system just doesn't work that way. We all do what the incentives tell us to do, and the incentives tell us to take care of sicker patients because that's what we get paid for. And so somehow we have to incorporate a principle that says we as a state in Massachusetts are making a commitment to keep our patients healthy. And the way we do that is really investing in primary care. Thanks.
Thank you, Barbara. Barbara Spivak.
Thank you. Sorry. Thank you. I don't want to completely repeat. I think we've had people say many of the really important points, but I really want to emphasize several things. That at the end of the day, we have to follow the money, because one of the reasons primary care is failing is that the money is not actually getting to the practices and helping patients get the care they need. And so I think whatever we do, we have to not only increase the investment, but we have to make sure that it's actually going to deliver care, better care. And on the concept of, I think we do need to go back to many of the concepts that we tried back many years ago, looking at alternative models of care, keeping people at home rather than having them go to the emergency room, getting people with certain diseases care earlier rather than waiting 3 or 4 days to see their primary care doctor. Easier access and access at home will really help. Those models failed because they were expensive to run and nobody cared that they saved money in the long run. We didn't, even with accountable care organizations and capitation, global capitation, the money came too late. You know, it was 18 months, 24 months sometimes, or even longer before we got the reward from saving money. We didn't have the money to keep the programs going. So we have to relook at how we fund these programs and go back to looking at alternative models of care that I think in the long run will really save us. Thank you.
Thank you. Brenda, then Aditya.
Hi, just a couple of quick points. On number one, I think it's great. We need to agree to shift away from fee-for-service. And I just wanted to sort of highlight one of the things that's happening is the current system isn't working. And, there are more and more direct primary care practices popping up around the Commonwealth. So just keeping that in mind is something that we have to be mindful of and how to sort of work within that or not. Number 5, I think quality is certainly really important. We have to watch the details of that as far as adding to that administrative burden. And then other things, in pediatrics, one of the quality metrics that I think that is continues to go forward, and an important one is vaccines and percentage of vaccine uptake. And with that, in this day and age right now, that gets very complicated for pediatricians who are compensated for their percent of their patients that are taking in the vaccines, but at the same time, they are not being compensated if there is vaccine, hesitancy based on recommendations from the federal government. So that leads to, complications, moral injury for pediatricians in general right now, and I think for all of us who are in that space, and which leads to, part of our workforce issues. So for 6 and 7, I would say, pediatrics is down in the match overall, and because of more moral injury on vaccines, and smart medical students looking at the financial inputs of medical school and the reward on return, that our match rates are going down and down and down. And part of that is that pediatrics is reimbursed or paid honestly less than for the same codes than internists are for the same thing. So what does that mean? And what my recommendation is on 7 is yes, definitely want to think about percent of payment for Medicare Mass Health being equal for our private practices. What we have, and certainly the FQHC should be making Mass Health rates, but I think Mass Health rates need to be at least closer to Medicare, which I know is often lower than the private practices. Mass Health has done some great things with some of the bigger practices and using the ACOs, but what I will say also back to an access issue, which becomes an equity issue, is that our pediatric practices that are in private practice are having a really hard time being sustainable with these tiny margins. And if they can't, they have to keep minimize the number of Medicaid patients, Mass Health patients are willing to take in order to be sustainable, which leads to a terrible access issue for number 6, which I think is access. And honestly, it's equity, right? So the patients that can't provide, that don't have private insurance, have harder time finding a general pediatrician. And we have a hard time keeping people wanting to come to pediatrics for those reasons. Thank you.
Thank you. Aditya, then Suzanne.
Thank you, Secretary. Happy New Year, everybody. I'm Aditya from C3. I'm here on Christina Severin's behalf today. This is a great conversation, great goals and principles. A couple quick reflections. Our first goal is patient access and experience. And when I see that, I think access and experience for whom? Because we're about to enter a pre-Romney care level of uninsurance in the state. So I'm not saying anything we don't all know, but just building off of comments from Wayne and others, if we don't have a component of this reform that addresses universality of access and coverage, we will severely undermine whatever progress we make on these other things. We increase payment for primary care, but 1 in 10 people walking into a health center is uninsured, uncompensated care, that money immediately is going away. It's being used to fill the hole, right? And if we increase access and choice, but for hundreds of thousands of residents of the Commonwealth, their front line for access to healthcare is a hospital emergency department, we have not actually increased access and choice. We've just exacerbated inequalities in access. So that is a really critical component of that, whether that's another goal or we expand on what that access and choice goal means. I think it is a really, really important principle for everything we do. Second, want to +1 Renee's comments about the inequality in economics in the state's healthcare system. We all know this. There are haves and have-nots in our providers, just as there are among patients, and that exacerbates structural underfunding in the safety net. So it is really important that whatever we do here has an all-payer rate-setting component for primary care in order to ensure that we don't make those things worse. Lastly, I would just call out, to avoid reinventing the wheel here, a lot of our goals and principles are really well exhibited in the Mass Health model, which couples primary care reform. I think Mass Health is the only payer in the state that has actually succeeded at increasing primary care spend as a proportion of total cost of care. So that is a really compelling reason to look at that model first. And they couple their primary care model with an ACO model. So there are strong incentives around keeping the population healthy, managing costs, keeping patients out of the hospital that allows for the investment in primary care to be affordable. Thank you.
Thank you, Aditya. Suzanne, then Senator Friedman.
Thank you, Secretary. And I want to echo the thanks to everyone who put together these goals and principles. I think they're the right ones. And as we get into the details, of course, there's some refinement. I agree with a lot of the comments that are made. And thank you to Aditya for recognizing the time that we're in. That's top of our minds as well as we're thinking about how people are going to continue to access care if they lose coverage, and do everything we can to make sure that people keep coverage. So on that equity note, for number 6, I also just wanted to mention around the access barrier that we see on the helpline. We see a lot of language access barriers, so just wanted to report that as something we see specifically from people every day when we're trying to connect them with primary care. This may not be specifically risk adjustment, but just something to consider as we're looking to incentivize providers to be able to have the resources they need to serve populations. And it's also a workforce issue, so there's the connection there. On number 5, I think, as Renee and Aditya just said, thinking about the Mass Health Subcap program and the tiers, I think one of the good things there is also, while trying to have some standardization and also including some flexibility for practices to meet their specific populations. Brenda talked about pediatrics, and I think they did a great job of recognizing the differences there. And also want to echo Barbara's comments about prevention and keeping people healthy, which is hard to do with a lot of the demands that folks have on some of the more acute or chronic conditions, and how can we balance that out over time. Lastly, I also want to recognize also the piece about capturing alignment and as many payers as possible. I think it's really important. We don't disagree with the concept of creating some sort of primary care fund to capture self-insured and other plans. But we need to get somewhere at least in between all payers doing their own thing and creating that fund. So I'm hoping that we can come to some agreement in capturing as many providers and payers as possible. Thank you.
Thank you, Senator Friedman. Then Jennifer.
Thank you, Secretary. So this is, I've been listening to everybody, and I think a lot of really important points have come up. Love the goals, and I want to respond to a few things. Totally agree with Renee. To the issue of the choice and consumer choice, we have consumer choice today. It's called high deductible health plans. Doesn't mean that people get the care they need. It only means that that they may be able to pay less, but we're just pushing the can down the road, because if we don't identify what it means to have primary care, and to have that primary care be the same across all platforms and all insurers, then all that's going to happen is more people are going to end up doing more invasive and expensive stuff because they haven't been able to get the care they need. So we've got to look at what it means to get healthcare and good healthcare first and not have us rush to do cost, because that's what we do all the time. And then we never have the level playing field or the understanding of what this is going to mean. So I think the other thing that I want to say is that I'm hearing a lot of people, well, we have to be able to do new models of care, and we have to, and new ideas are going to come up. But isn't that the purpose of doing prospective payments for primary care practices, so that they have the ability to adopt new models, so that they can increase their efficiency and their cost? It's like that should be part of what we are allowing them to do with flexibility, right? And so what I'm worried about here is that we make this so fine or so kind of particular that we're not going to be able to come up with a fundamental framework for what primary care is and how we should deliver it, right? But what I'm hearing is, if you go back to what we were actually laying out with our principles, you will be able to do what Dr. Dixon talked about. You will be able to do what other people have said about, do medical homes work for them? Do they not? What's good for your population? Should we increase telehealth? Should we be going directly to people's homes? All of that gets to be decided, I think, if we do the right primary care model, because we're not telling people what we're paying for and what we're not paying for. And then finally, this is my great bugaboo, and I will say it wherever I can. There is no reason on the planet why we should allow insurers to pay less than Medicaid to FQHCs. I don't care what it does. We should never be subsidizing through mass state dollars. We should not be subsidizing the insurance companies for people who are getting low income and are getting help through FQHCs. No reason in the world, and I will die on that hill. So thank you.
Thank you, Senator. Jennifer, then Lauren.
Hi, so good morning. Thank you, Secretary. Happy New Year, everyone. First of all, to reiterate what many people have said, I appreciate these core goals and principles. In terms of the goals, focusing on 3, as a licensed clinical social worker, I'm going to continue to sort of focus my energy on supporting team-based care models. I think there's a lot of resources that we don't utilize when it comes to supporting our primary care providers. And I think if we better manage mental health and behavioral health care and better support our primary care providers in these settings, we're going to reduce costs. So I want to continue to put a lot of emphasis on 3, which is supporting team care, team-based models, because if we de-silo care, we share the responsibility, and we really look at and better examine our workflow efficiency, I think we're going to get to a place where we can not only provide patients with better care and better mental health care, we're going to reduce costs, but we're also going to, really improve the future of what our primary care providers can do. And also when we take a look at just their physician self-care and reducing their burnout. So thank you all.
Thank you. Lauren?
Laura? Me? Yeah, okay. Thank you very much. Happy New Year. I just want to say I am day 7 on owning a primary care practice, independent practice. I've got 1,500 patients, and already I have a full-time person working on authorizations and referrals. And this is someone that I had intended to make sure that they were engaged in the other C's, like coordination, continuity of care, and being our first contact. So day 7, already quite overwhelmed with the administrative burden. And so want to put out there that whatever we're doing, and Renee, I hear you 100%, we're this tiny shop, there's 5 of us, and to take a full-time FTE and point it toward going onto portals to fill in information and for a payer is quite frankly disturbing, because we have a lot of patients that need care, the hands-on delivery care and meeting face-to-face with our staff. So just again, want to push whatever we can do to reduce administrative burden and make sure things stay simplified. And I do think that this also speaks to being forward thinking and making sure that we've got simplification across the whole board. And that includes moving toward any sort of alternative payment models, making sure that is as simple as possible. So if that means contributing to a sustainability fund and having it be a simple way for us to go ahead and ensure that we're getting appropriate reimbursement for the care that we're delivering, I think that that would be a very helpful way to go. And please don't add any more administrative burden onto what our team is already doing.
Thank you, Laura. David, since you and your team have been taking copious notes and wondering, I'll open it up to you in terms of where you would like the group to give you input next.
Thank you, Mr. Secretary. And thank you for this conversation. I think really helpful and insightful. And I just wanted to reflect on a few points. One, on, there was a few comments here around, I think, a reflection that the team-based care model has been a failure. And I guess I would just encourage those that share that perspective to reflect back to us, what would it take to make that a success moving forward? Because I guess I still share the feeling that there is a lot of promise in that model. If we can do that right, I think Dr. Spivak, you talked about perhaps some of the ways that the payment model in the past hasn't necessarily rewarded that, and how might we think about some principles and payment models that could support that. And also, I think Senator Friedman, I just wanted to share, I think, my personal perspective that I think one of the principles here is around the flexibility of the payment to enable that type of innovation that could be different ways of delivering care that meet the needs of patients. And I think when I thought about that, the first goal in the kind of the goals section, around enabling provider flexibility to be able to provide care in different ways, I thought about kind of the range of different things and things that we may not even be thinking about yet in terms of how we might use technology and people in different ways to be able to provide care, and how payment reform might unlock that ability to do that, and how might our recommendations help support that. So I just wanted to reflect a little bit on that. And Mark Freeberg, I saw you raise your hand, and so I'm happy to hear your thoughts perhaps on that comment as well.
Yeah, just in direct response.
Mark Renee, then the senator. I think I saw her hand. Sorry. So go ahead.
Yeah, just in direct response, Dave. Great question. The problem with sort of the medical home and every model like it, advanced primary care, comprehensive primary care, whatever flavor and name it had over the years, is that it told you exactly what structural capabilities you had to invest in, or you had a menu to choose from. But it was always there was a kind of a point system. Some were must pass, some weren't. It's kind of like how health plans get accredited as well. And that just really impinged on the kind of freedom that primary care practices should have, I think, to really optimize what they need for their specific patient populations. You might run a primary care practice, know that you need, because the population serves something specific. Guess what? It's not in the required list to get level 3 payment. And so because you think you need that money, and maybe you can subsidize from that extra payment the thing you actually need, you invest in a whole bunch of stuff you don't need. And that actually really increases burnout and burden for primary care practices everywhere it's been tried, unfortunately. So the solution here is just not to have those structural requirements. Move to capitated payment without them.
Thank you, Mark. I think that's a helpful clarification. Not so much that an objection to the concept of team-based care, but in how we might pay for that or support that, not being so determinative in kind of the payment structures, that it's a point-based system, but really you're suggesting perhaps provide more flexibility to the practice to think about how best they want to design that care team to best meet their patient needs, rather than a more prescriptive type of structure. Is that fair? I'm not hearing nods. Okay, thank you.
Renee, then Aditya.
Yeah, sort of reinforcing what Mark spoke to and the senator. What we're looking for is the prospective payments. The team-based care is the way that, I know that my organization is approaching this, and we've been able to do that because of the subcap. And because of the subcap, we have completely remodeled the way that we're doing care. But what terrifies me is that the subcap may go away in 27. And what also terrifies me is the subcap only covers 33% of my patients. 67% of my patients are outside of that. And I'll tell you, the biggest team-based care I have at my organization is my finance department. I've got more people in my finance department that have been working as a team, outreaching to all of these. I have in the top 85% of our payers for our patient panel, we have 17 different payers. 17 different payers. I need either very consistent things needed from them. I don't need denials and turnarounds. I need to not fight to do good care. We want to do good care. That is why we're here in medicine. And that's why we're in primary care. We want to take people, whether they're sick or healthy, and make sure that they have the life that they're looking for. What we really actually need is exactly what Mark said. It's the prospective payments that allow us to build the models that work for our organization. And Dr. Black, so proud of you opening up independent practice, and I want you to be able to keep it going. And I want folks to roll out of residency, whether NP or FM or PEDS, and say, or IM, should it happen, and say, I want to open a practice. You know why? Because I want to take care of patients, not because I want to fight with insurance companies. Laura, love the insurance company. I don't want you guys to go away. Don't have a problem with that. But I would like to only deal with one entity. And what terrifies me also, David, I'm going to bring this in, is that Massachusetts has an ability to make the simple complicated. That won't work. Let's make the new Mass design, making the complicated elegant. Let's be as simple as possible and let people do their job, pay them all the same amount of the money, and yes, monitor quality. And John, 100%. The number one thing is patient access to excellent care, and they get to choose where they go, 100%.
Aditya, and then we'll close with Wayne.
Thank you, Secretary. So on this excellent discussion about prescriptiveness versus flexibility on the dollars, I'll kind of brag on our organization to offer an example and then also offer a potential caution. So the example C3, we have two things going for us. We have prospective capitation on most of our primary care through the Mass Health model and other capitated contracts we've negotiated. And then we also have ACO economics on most of our population. So I don't want to lose that part of the conversation as well. Good primary care, I think this has come up before in the conversation today, saves dollars on total cost of care in the rest of the system. What normally happens is that surplus value is then captured at the payer level, and those savings are used to underwrite higher rates of payment for high intensive care or paying providers that have a lot of negotiating power. That is what happens in a market of healthcare prices. In an ACO model, the population health economics trump that. So the surplus value that's generated off of the excellent care that FQHCs provide gets returned to us, and we reinvest it in the primary care model. We've replaced a vicious cycle that exacerbates inequity and sucks money out of primary care with a virtuous cycle that puts that money back into it and allows us to expand the model. We've used that to do basically everything you could possibly want on innovative primary care. We've created a technology company. We have our own instance of Epic. We have gone big on AI scribing to reduce provider burden on documentation. We are looking at innovative models of triage. We have care teams that are experimenting with hour-long visits for complex patients as ways to kind of optimize the model of care for population health outcomes. We have a centralized care management team. We have embedded care management with health centers. We have the largest social determinants program in the state. All kinds of cool stuff. And it comes not because we're being told to do all those things, but because we have a financial incentive to do all of them. Now, the cautionary note I would say is for primary care that doesn't look like health centers or independent practices, that is part of a hospital system, it is much harder to track the economics. So if you increase the rates of payment for primary care, how do you make sure those dollars stay in primary care when there are a lot of black box funds flows and value transfers between primary care and the hospital system? One of the ways to do that is to have some expectations for what primary care looks like. And this goes back to the senator's point of we need to define what the hell it is we're buying, right? And if we define what primary care looks like from an access and a capability standpoint, that is one way to make sure that when you give the additional investment dollars, they're actually spent building that thing, as opposed to, nominally doing that, but in practice, they're actually going to a cancer center or a radiology department. Thank you.
Thank you. And our final speaker for today is Wayne.
Okay, I'll try and be brief. This primary care task force recommended that we double primary care investment. I believe that we have a responsibility with that doubled primary care investment to produce a much better product in advanced primary care with that doubling of primary care investment. The tiers, I think, have had some pluses and minuses, and we have tweaked, really emulated that tier concept, but tweaked that concept in the primary care for you model with our 20 transformers. And with the transformers, each one of these 20 items, you get to choose what's appropriate for your practice, your clinicians, your patients, and your communities. And then invest in those things. And I believe that that can work and help us incentivize advanced primary care with our doubled primary care investment. Thank you.
Thank you for that great discussion. David, I'll turn it to you for some wise integrative points, but also our next steps so that people know what's happening with all the wonderful comments or criticisms that they had to our core goals and principles.
Thank you, Mr. Secretary. Thank you, task force members, as always. What we've accomplished and discussed in 90 minutes is truly incredible. And Renee, simple but elegant. That is a challenge for all of us here in Massachusetts. As you said, we love to overcomplicate things, but we will put that on the masthead, and I will put that Post-it note on my computer as we continue this work. I think that's critically important. This was all really helpful. I think we're going to take all of this back and continue to help refine these goals and principles. We would encourage you, as always, to continue to share your thoughts with us offline through Kelsey. One of the things we really didn't discuss as much today with these goals and principles is kind of the how and the kind of the mechanics of how we will achieve these goals and principles. And by that, I mean kind of the government of it all, and where does this sit, who is helping design these principles, within, is that Division of Insurance, is that HPC, is that a primary care advisory group? And so there are some, I think, other parts of this deliverable and recommendation that we'll need to continue to think about. And Dr. Altman, as I think about the Primary Care Transformation Fund, I think of that kind of in the how we might achieve some of these principles. And so we'll need to continue to work on that. But I think we've made great progress today. And overall, my sense is that there is a lot of consensus and agreement on some of these core principles and goals. So I really appreciate today's conversation. We will continue to push forward on all of this great work. And look forward to a really, really successful year working with all of you. So a great kickoff to the year. We'll be in touch with scheduling for the work groups. We are planning to reconvene the workforce work group. We want to continue to focus on improving the working conditions for primary care providers. That's a huge focus for the workforce work group. So we're going to be polling members of that workforce work group around priorities for the next meeting that you want to focus on. Data and research, we're also going to be reconvening. And we had polled members earlier, I think late last year, on a potential next meeting. So please book your calendars now for March 4th for our next full task force meeting, but we'll be in touch with much more information to come. So thank you all. Mr. Secretary, you have the final word.
I would say that I was impressed by the level of knowledge, expertise, and also passion that you displayed. And I'm hoping that we can do it justice as we're seeking to come up with a set of recommendations that is both transformative and yet that we can increase the chances of that it would be supported by the legislature and as it goes through the process. So that'll be a challenge, but I think that we're all up for it. And I look forward to our next meeting. So I will then turn it over to David for closing us. Do we need to vote or anything like that?
Nope. We are adjourned. Thank you.
Okay. Thank you, everybody.